Welcome to the Deep Dive, where we sift through stacks of information to get right to the heart of what you need to know. Today, we're plunging into a topic that, well, it affects every one of us. Patient safety in hospitals. Specifically, how technology is fighting medication errors. We're going to unpack a really groundbreaking piece of research that really shapes how hospitals make care safer, focusing on a pretty innovative testing method.
Yeah, you've shared a really insightful paper. It's from Kilbridge, Welebob, and Classen, published back in 2006. And our mission for this deep dive, really, is to understand how this world-first test was developed. A test to truly evaluate how effective computerized physician order entry systems, CPOE, were at preventing adverse drug events, right there in the hospital setting.
Okay, so let's really get into this. We're talking about a genuinely groundbreaking system, evidence-based, designed to put CPOE properly to the test. In real hospitals, this wasn't just like theory.
No, not at all.
It was about practical application, testing the tech where it matters, and ultimately, safeguarding lives. It feels like a huge step.
Absolutely. And to really understand the urgency behind it, we probably need to rewind a bit. Back to a really foundational moment in healthcare safety. That was the 1999 Institute of Medicine report, famously titled, "To Err is Human."
Right, that one made waves.
It really did. Imagine this sort of silent epidemic, sweeping through hospitals, an unseen danger maybe lurking in every prescription pad. That report, it bravely exposed just how frequent and, crucially, how costly adverse events in medicine actually were. It really pulled back the curtain on a problem that maybe had been overlooked for too long.
And the numbers from back then, they really drive home the scale of the problem, don't they?
They do.
Adverse drug events, ADEs, they were identified as one of the leading categories of patient injury. I mean, one major study mentioned in our source, the Harvard Medical Practice Study, found they accounted for, 19%? 19% of all adverse events.
Yeah, it's shocking. Nearly 1 in 5 incidents of harm to patients traced back to medications. And what's truly staggering is the sheer scale when you look at patient admissions. The paper highlights studies indicating anywhere between 6.5% and maybe even 20% of patients admitted to U.S. hospitals were suffering an ADE.
Wow, up to 1 in 5 patients admitted.
Exactly. And these weren't minor things, minor hiccups. They came with a significant price tag, estimated back then at around $2,000 to $2,500 per event.
Per event.
Per event. And that cost was largely due to patients needing longer hospital stays because of the ADE.
So for you, the listener, whether you're thinking about this as a patient, a family member, or just someone interested in how healthcare works, this meant a very real, tangible risk every time someone entered a hospital, plus just a massive financial drain on the whole system.
Mm-hmm. Clearly, with stakes that high, something bold had to be done, something had to change. So in direct response to these, frankly, alarming statistics and that big call to action from the Institute of Medicine report, November 2000 saw the formation of the Leapfrog group.
Okay, the Leapfrog group.
Yeah, and this wasn't just another committee, It was a powerful coalition of healthcare purchasers, kind of acting like a consumer watchdog, really, dedicated to pushing for these great leaps forward in healthcare safety and quality across America.
Right, using their purchasing power to drive change.
Precisely. They understood that collective action and, importantly, clear standards were needed to actually move the needle.
And this is where it gets really compelling, I think. Leapfrog didn't just pick any issue, did they?
No, their first major target was computerized physician order entry, CPOE.
Okay.
They chose it specifically because it seemed to have this huge potential to dramatically cut down on medication-related harm. The idea was basically CPOE could act as this sophisticated digital guardian angel for prescriptions.
Like a safety net.
Exactly, a digital safety net, catching errors before they ever reach the patient.
But their standard wasn't just go buy a CPOE system, was it?
No, far from it. It was much more rigorous. It actually required that the CPOE system, as implemented in the hospital, could reliably alert doctors to at least 50% of common, serious prescribing errors.
50%, that's a high bar.
It is. And what's fascinating here, and a key driver for this whole testing methodology, is that early studies on CPOE effectiveness, well, they were often done by the developers themselves.
Ah, right. potential bias there.
Exactly. Raises questions, doesn't it? And independent evaluations often showed, well, less impressive results, less efficacy. Plus, and this is critical, there was a real concern that poorly designed or maybe badly implemented CPOE could actually introduce new kinds of errors.
Oh, wow. So the tool meant to help could actually create different problems.
Potentially, yes. Imagine a system meant to prevent harm accidentally creating new pathways for errors to happen. So this made an independent, really robust evaluation process not just helpful, but absolutely vital. You had to know if it was actually working safely.
Okay, so recognizing this critical need, the Leapfrog group, with some key funding help from the Robert Wood Johnson Foundation and the California Healthcare Foundation, they contracted First Consulting Group. And their mission was clear: build this unbiased evaluation method.
Right. A way to truly assess these CPOE systems in action, in the real world, which, raises a really important question. What does a good, effective evaluation methodology look like in this kind of context?
Yeah, what were they aiming for?
Well, the paper outlined several key principles that guided the development. First, it had to actively promote the development and adoption of safety functions within CPOE systems, sort of pushing the industry forward.
Okay, so driving improvement, not just measuring.
Exactly. Second, it needed to serve as a practical quality improvement tool for the hospitals themselves, not just some pass-fail test they dreaded.
Makes sense.
And third, critically, it had to test both basic decision support and more leading-edge stuff. And importantly, provide feedback about alert fatigue.
Yes, alert fatigue, the bane of clinicians everywhere.
Right, that very real problem where you get so many alerts, especially maybe false positives, that clinicians just become desensitized. They start ignoring them.
Which completely undermines the whole point of the system.
Precisely. So it's not just about catching errors. It's about making the system usable, effective, and truly integrated into how doctors work without just overwhelming them.
So how did the methodology actually work? You said it simulates scenarios.
Yeah, the methodology itself is actually quite clever. It simulates different, often quite tricky clinical scenarios. It uses a wide variety of test patients, test orders, basically trying to see how the hospital's specific CPOE system responds when faced with a potentially unsafe situation.
Okay, walk us through that process. How does a hospital actually take this test?
It's pretty well structured for a real-world test. So a hospital taking the evaluation first downloads a list of test patients. And these aren't generic profiles, they're detailed. Diverse demographics, different medical conditions, existing medication lists, the works.
So realistic complexity.
Exactly. The hospital then programs these detailed patient profiles into their CPOE testing environment, not the live one. And they have a time limit for this, about 4 hours, to keep it practical.
Okay.
Then, within that window, they download a series of test orders, and they have to enter them into their system for these test patients.
And then report what happens.
Yep. Within a strict 2-hour window after entering the orders, they report the CPOE system's response online. Did it generate an alert? Did it block the order completely? Or did it just accept it, no questions asked?
And the output isn't just pass-fail.
No, that's key. Hospitals get an overall score, sure, but critically, they also get specific scores for different categories of clinical decision support. This detailed feedback is absolutely crucial. It lets hospitals pinpoint exactly where their system needs improvement or maybe where they need to add new decision support functions entirely. It's designed as a tool for continuous refinement.
That makes a lot of sense. But
Yeah.
how did they stop hospitals from just, gaming the system, pre-programming it to pass?
Good question. They thought about that. To maintain integrity and prevent gaming-like hospitals tweaking their system just for the known test cases, the specific scenarios and test orders are never fully published. Instead, hospitals receive a random subset of orders drawn from a much larger master set of potential orders.
So they can't know exactly what's coming.
Highly unlikely. And furthermore, that master set itself is periodically reviewed, revised, and updated. New orders, new scenarios get added to keep it current and valid over time.
That's incredibly smart. Really ensures the test stays a true reflection of the system's day-to-day capabilities, not just its ability to pass a known exam.
Okay, but given all the different kinds of errors that could happen, how did they actually score these systems? What counted more?
The scoring system was very deliberately evidence-based. It was designed to reflect the relative importance of preventing different types of harm. So it takes into account two critical things. One, the potential severity of an adverse drug event if the system doesn't catch the error.
Right, like how bad could it be? Life-threatening, severe. Exactly. They categorized severity based on expert opinion life-threatening, severe, significant, or not significant. And the second element was the likely frequency of that error happening in the real world.
Ah, okay. So how often does this kind of mistake actually occur?
Precisely. So a rare but potentially catastrophic event, maybe like a severe allergic reaction getting missed, that would get a high score. But similarly, an event that's maybe less severe but happens really often could also get a high score because of its cumulative impact across many patients.
That seems logical. Where do they get the frequency data?
The paper notes that the likely frequency data came from several large published studies looking at automated ADE surveillance, basically, systems designed to detect ADEs. This was considered much more reliable than, say, relying on doctors voluntarily reporting errors, which often underestimates the true frequency.
Okay, so severity and frequency combined into a score using some kind of matrix.
Yeah, a detailed matrix then combines these attributes, the severity rating, and the likely frequency to determine summary scores for different types of errors and an overall score.
That's a really comprehensive approach. It's not just about catching any error, but catching the right errors, the ones posing the biggest threat or happening most often. So let's dive into some of those specific error types the system was tested against. The paper outlined, what, a dozen different categories?
Yeah, 12 categories of clinical decision support, and you can really see the depth they were aiming for here. These categories were meticulously designed to catch a really wide range of potential problems.
Covering the bases.
Absolutely. They covered a spectrum, from the kind of obvious things like checking against a patient's known allergies or making sure two drugs don't dangerously interact, to more nuanced dangers. Things like incorrect doses based on a patient's age or their weight or maybe even their kidney function from lab results, or even checking if a medication is contraindicated by their specific diagnosis.
Okay, so give us some examples. What were some key categories?
Sure, there was therapeutic duplication. That's where a new order might unintentionally overlap with a medication the patient is already taking.
Right, like two drugs from the same class.
Exactly. Then single and cumulative dose limits, checking if a prescribed dose, either a single one or over time, exceeds recommended safe ranges.
Yes.
Then the really critical ones like allergies and cross allergies, the system has to flag a documented allergy.
That's a bare minimum, surely.
You'd hope so. And then there's the chilling example they give of contraindicated route of administration. The paper specifically mentions intralechical vincristine, a chemotherapy drug that's absolutely catastrophic, often fatal if given into the spine instead of a vein. The system should block that.
Wow, okay.
Other crucial ones included drug interactions, obviously, but also drug-food interactions, checking for dangerous combinations there. Then, as I mentioned, contraindications or dose limits based on patient diagnosis or based on specific patient age or weight.
So tailoring the check to the individual patient.
Precisely, and a really important one. Contraindications or dose limits based on laboratory studies. The classic example is checking potassium levels if someone's ordering digoxin. Too low potassium makes digoxin much more toxic.
Right, using lab data in real time.
Yeah, or even considering radiology studies, like flagging potential interactions with IV contrast medium if the patient has poor kidney function.
Okay, that's comprehensive. Were there others?
Yes, a few more interesting ones. They tested for corollary intervention, like does the system prompt the physician to order necessary follow-up tests, like drug levels, when prescribing certain medications that need close monitoring?
Ah, prompting best practice.
Kind of nudging them, yeah. Plus, they looked at efficiency checks like cost of care, maybe flagging potentially duplicate lab orders or imaging studies.
And crucially, that alert fatigue issue.
Absolutely. They included a measure for nuisance alerts. Essentially, how many trivial or inconsequential alerts does the system generate? This is vital for tracking and minimizing that alert fatigue, making sure clinicians actually pay attention when a serious alert fires.
Okay, so they developed this really thorough methodology, but the theory is one thing. Did they test it in the real world before rolling it out?
Oh, absolutely. That was critically important. The methodology wasn't just theoretical, it had to be validated in actual hospitals. The goals were basically threefold. First, to confirm it could accurately reflect how a CPOE system really performed in a live environment.
Did it measure what it was supposed to measure?
Exactly. Second, to ensure its practicality. Could hospitals actually do this evaluation without it being an overwhelming burden?
Right. Could they fit it into their workflow?
Mm-hmm. And third, to refine the methodology itself based on that real-world use and feedback. Learn from the experience.
So where did they test it?
They took the methodology and piloted it at 6 different medical centers across the U.S. And importantly, these sites used a mix of systems. Some had commercially available CPOE systems, others had custom-developed homegrown ones.
Okay, so a diverse testing ground. What did they find? Did it work? Was it practical?
The site visits were revealing. They found that programming those detailed test patients typically took less than 2 hours, well within the 4-hour limit they'd set.
So feasible.
Feasible, yeah. And entering a representative subset of the test orders usually took about an hour. So it demonstrated the basic practicality of the whole evaluation process. They also refined the reporting format based on feedback, simplifying it down to just 2 clear descriptions for each test order outcome.
Which work?
Either alert or information received or order blocked, meaning the CPOE did something, some kind of decision support intervention occurred, or simply order accepted, no alert or information received, meaning the potentially problematic order just sailed right through without any system intervention. Made data collection much clearer.
Okay, practical, refined. But what about the actual performance? This is where the rubber meets the road, right? What did it show about how well these CPOE systems were actually working?
Yes, and this is where it gets really interesting and shows exactly why this kind of independent testing was so vital. It exposed a significant and sometimes, frankly, alarming range of capabilities, or maybe lack thereof, across the different systems they tested.
Like what? Give me an example.
Okay, get this. For the category of drug diagnosis interactions, checking if a drug is wrong for a patient's underlying condition, none of the 6 systems tested were able to generate any alerts or responses. 0.
Wow, 0% on that one. That seems like a pretty big gap.
It was a huge gap, and it highlighted a sort of foundational flaw in how early CPOE systems were often designed. They might have been okay at spotting drug interactions, but they hadn't yet cracked the much harder problem of understanding the full clinical context of the patient's diagnoses when evaluating a drug order. This category was included specifically to push vendors to develop this capability.
Okay, so drug diagnosis was a big miss. Were other critical categories performing better?
Well, inconsistently is probably the best word. Take therapeutic duplication, for instance. Only 3 of the 6 sites had operational alerts or even just showed extra information for that. And significantly, one of those centers had actually turned off the therapeutic duplication alerts after initially implementing them.
Why would they do that?
Because the drug interaction database they were using, which came from a third-party vendor, was generating too many false positive alerts. It led directly to that alert fatigue we keep mentioning. Doctors started ignoring all the alerts because so many were irrelevant.
The boy who cried wolf effect, basically.
Exactly. Potentially life-saving alerts getting lost in the noise. And it wasn't just duplication. Only 2 of the 6 centers had dose limit checking working for most of the orders tested. 2 others only checked for a few specific drugs.
So spotty coverage even on dosage. What about allergies and drug interactions? Those seem fundamental.
More common interactions, yes, they did better there. 5 out of the 6 systems did fire alerts for drug and drug allergy interactions. But even there was variation. One system only checked for allergy interactions within the pharmacy system, not directly when the doctor was placing the order in the CPOE.
So the alert might come too late in the process.
Potentially, yeah. It shows that even for these really critical safety features, there was just huge variation in how effective or even how operational they actually were in practice.
And beyond just getting an alert, what about the strength of those alerts? Did they just flash a warning, or could they actually stop a potentially dangerous order?
That varied widely, too. The alerts ranged from something quite passive, like just showing an on-screen reminder of a patient's current lab value, like their low potassium, while the doctor's ordering digoxin.
Just information display.
Right, or maybe just displaying the patient's age if it's relevant for dosing. That was one end. At the stronger end, some systems implemented a hard stop, meaning the order was actually prevented from proceeding any further unless the doctor provided specific documentation, a reason for overriding the alert.
Okay, a much more forceful intervention.
Definitely. And this really highlights the different philosophies and technical approaches that various CPOE systems took towards clinical decision support, and consequently, the very different levels of protection they might offer patients.
So taking all these findings from the real-world tests, what did this mean for the future of CPOE evaluation? How did the methodology evolve based on this?
Well, an overall grading system was developed. It built on that severity and frequency scoring scheme we talked about, and also reflected the actual performance they saw during the pilot testing. The strategy was smart. Initially, they emphasized the functions that, frankly, most CPOE systems should have been able to accomplish: basic safety checks.
Setting a baseline.
Exactly. But critically, the plan was always that the requirements to achieve a satisfactory evaluation would become progressively more stringent over time.
Pushing for continuous improvement.
Right. Pushing hospitals and vendors to continuously strengthen their system's decision support capabilities year after year. And the whole methodology was then made accessible via a secure, web-based program. It had user IDs, security codes, those strict time constraints for each stage we discussed, and even mandatory lockout times between attempts, again, to prevent repeated attempts at gaming the system.
Really locking it down.
They tried to make it as robust as possible.
So this report, it really describes the development of the first truly systematic, evidence-based way to evaluate CPOE systems as they are actually implemented and operating in hospitals.
That distinction seems key, not just what the vendor claims it can do in a sales demo,
Exactly.
but what it actually does in the messy reality of a busy hospital. That feels like a huge difference in healthcare technology.
It's a massive distinction, precisely. And while this was indeed the first test developed specifically to certify electronic health record applications in actual use within hospitals, the paper notes it was really just the beginning. Similar efforts were already starting up to certify electronic health record products at the vendor level before they even got to the hospital.
Like pre-market approval.
Sort of. Organizations like the National Certification Commission for Healthcare Information Technology, CCHIT, had been created around that time. Their goal was to accelerate the adoption of health IT that could genuinely improve quality, safety, and efficiency. And they aimed to do that by setting up an efficient, credible, and sustainable process for certifying these IT products across the board. So it's all about ensuring these complex systems actually deliver the benefits that everyone, providers, payers, patients, expects and hopes for.
Absolutely. A robust certification process provides a much clearer definition of what a product can actually do, its capabilities, its compatibilities, and it also helps ensure interoperability, that these different systems can talk to each other, which is vital for emerging local and national health information networks. It reduces the investment risk for hospitals buying these systems and encourages payers and purchasers to offer incentives for using certified, proven technology.
Wow, what a deep dive that was into the real nitty-gritty of patient safety and technology. We've really seen how that pressing problem of adverse drug events, highlighted by is human, led eventually to the Leapfrog group, and then to the development of this incredibly sophisticated independent testing methodology for CPOE systems.
Yeah.
It's just such a powerful, tangible example of how systematic, evidence-based evaluation can drive real, measurable change in healthcare safety.
Indeed it is. This paper from 2006, it really laid the groundwork for how we think about evaluating critical healthcare technologies, not in a vacuum, but in their real-world context. It underscored that it's not just about having the technology tick in a box, it's about ensuring it truly functions as a robust safety net, actively detecting and preventing serious medication errors before they can harm patients. It shows the incredible effort that goes into making sure technology actually delivers on its safety promise.
And for you, the listener, understanding this detailed process, I think it reveals the complex and frankly vital work happening behind the scenes every day to try and make healthcare safer. It's really a testament to the idea that knowledge, especially knowledge about how errors happen and how systems perform, is most valuable when it's understood, measured, and rigorously applied.
So reflecting on all of this, what stands out to you from our discussion today? Well, it definitely raises an important question, I think, for you to ponder. Given the clear success and impact of this CPOE evaluation methodology in pushing for safer medication practices within hospitals, what other critical areas of healthcare, or maybe even completely different industries outside of healthcare altogether, might significantly benefit from similar rigorous, independent certification processes for the crucial technologies they rely on every day? What innovative solutions, what improvements in safety or efficiency might arise if we applied that kind of scrutiny more broadly today?
That's a great question to leave things on. Until next time, keep digging, keep questioning, and keep learning.